Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week we talked to Stephanie Brenner. Stephanie is a licensed clinical social worker at Chronic Illness Psychotherapy in Evanston, Illinois. She also happens to be living with IBD for 23 years and living with a permanent ostomy. She specializes in working with kids and adults with chronic illnesses. And so we talked to her about what it's like to do therapy with kids with IBD. We talked to her about hypnotherapy. We talked to her about taking IBD on as part of your personality and what you do. We talked to her about addressing challenges with your care team. We talked to her about medical gaslighting, pretty much anything mental health related. We think you'll love her. Cheers.
Hi, everybody. Welcome to Bowel Moments. This is Robin.
Hey, guys. This is Alicia, and we are so very excited to be talking to Steph Brenner. Steph, welcome to the show.
Thanks so much. I'm happy to be here.
Well, we are very excited to have you because you are in our dual category. So I'm very excited for people to hear your story and to talk to you about both your personal story, but also your professional side of the world for you. But our very first unprofessional question is, what are you drinking?
Funny you ask. I'm drinking some bougie smart water. It's not a commercial, but it's keeping me hydrated. And I had a long day, and I knew if I had booze right now, it would disrupt my sleep because I'm in my 40s and that's what happens. And I have to wake up early. So I'm having some good old water.
Excellent. And yes, wild experience. Like all of a sudden you're like, why can't I sleep anymore? And like, why can't I drink alcohol the same way anymore? It's just really kind of, yeah. There's so much great that comes with it. Like this like sense of release of like other people's expectations and like all these great things that come with it. And then you're also like, but also how come I can't sleep? That's the one for me is like that I would just want to sleep like I'm 20 again.
Agreed.
Robin, what about you?
As someone who is turning 50 this year, I am drinking different fancy water, sparkling water, La Croix, but then I also have flat water too.
I mean, listen, go with a good thing and have it both ways. I appreciate this about you, Robin. Well, I am also drinking sparkling water. I'm drinking a pineapple sparkling water, though, and also a Sauvignon Blanc, which they probably don't really go together, but oh well.
Cheers.
Cheers, guys.
Love it. Cheers.
Steph, it is not about what we're drinking. It is about you. So next question for you is tell us your IBD story.
Such a loaded one, but also such a great one. That's why I'm here. Let's see. So it all started, I will be looking down at points, referencing what I call my medical resume. Also something professionally I encourage patients to have if they have a long history, which has name, date of birth, and it can only be one page. Like a regular resume, only one page. You get current meds, your allergies, your specialists, health issues, and then your surgical or hospitalizations. So sometimes I like, because it's been since 2000, so 23 years of doing this, there's been a lot of twists and turns. So I like to just have the benchmarks. And because of medical PTSD, I've blocked many of them out, but I will try and touch on as many as I can in a logical time frame. So I didn't know anything about IBD before college. So I was graduating high school and really sudden onset, blood in the toilet. And I knew that was not right because I was not on my period. So I luckily had a, safe enough relationship with my mom that I could say that. She took me in right away, went to a GI, diagnosed with UC pretty quickly. It was a pretty severe case. They threw a ton of prednisone at it. And since there wasn't much else we did, I think prednisone kept me going for a little while. Had the chipmunk cheeks for a good year. It was amazing. They were just wanting to prevent surgery because there were not back then a lot of medical, medicines available. Did enemas, did methotrexate injections. The only thing they had back then was Remicade. And so eventually I did Remicade after I just failed all those pills. They had me on 20 pills of Azicol a day. Again, back then it was bottom up. So we're going to try a whole bunch of, they weren't get you in remission tomorrow. They were well, we'll just try it. We'll save the Remicade. But within the first year, I never stopped flaring and I just couldn't get it under control. And they said, you definitely have UC and Remicade didn't work. And so you need to get surgery and get your colon out and then you'll be cured. That was one of those ones where they use the C word. That's a no-no. we went to Mayo for a second opinion. I'd never broken a bone or really been in a hospital before. So I was like, I mean, this is just a very weird world. But like, if you need to take this organ, like I'm miserable. I'm going to the bathroom 30 times a day. It was really bad. So they confirmed that's what we needed to do. And I got my surgery back so I was diagnosed in 2000. They did a 3-step. It was like, you couldn't do it in 2. We needed to spread it out. They did it around like my college final, like the schedule. I did a 3-step J pouch. So I'd had a temporary ostomy back then for I think 9 months. And I managed it decently well, which, spoiler alert, I have an ostomy now forever. And so that actually was a positive experience. I wouldn't say it was fun, but just knowing that I could do it, even in my 20s as like a dumb college kid, that really did help me feel like, okay, I know that quality of life, and it does really give you a lot of control back. So fast forward, have the J pouch. Actually, I shouldn't fast forward. Immediately, it starts getting pouchitis, is what they were calling it. Spoiler alert, it was Crohn's. But they kept saying, maybe this will just put you on antibiotic. We'll basically just put you on all the same medicine you just got off of. It was an angry pouch. It did not like to be in there. I think we got on a decent regimen once Humira came around. That kind of put things in remission for a while. So that got me through the end of college of just I'll just have this J pouch. And then I started getting symptoms. It was 2012 of a rectovaginal fistula, misdiagnosed for a good 2 years of this is a yeast infection or this is chronic gynae issues. Finally had a lovely complex gynae person that figured out this is definitely a fistula, and it just was never detected on any of the imaging because it was so low. And so that's something that I always tell patients if they have anything and they're like, nope, there's nothing there. And that you are either passing gas or stool out of the wrong hole. You will know. You will just know. There's a knowing in a weird way. So ask for a fistulogram, ask for more imaging, ask for a specialty gynae. But once they figured that out, they tried a bunch of these a fistulectomy, this rectal advancement flap thing to try it, and basically just patching it over. It's going to eat right through. I'm not sure why. I think I just, again, wasn't quite ready to do an ostomy. I was like, well, let's just try everything available. Fibrin glue, terrible idea. They all had pretty low chances of helping me, but I just, again, mentally was like, let's try it. Had cetons, all really unfun things. And eventually got to a quality of life where I was like, I think give me the temporary. I'm not committing to forever, but give me a temporary ostomy just so I can have a loop. And I know I've managed that before. So that was in December of 2012. Got that. Had actually kind of a rough surgery where my bowel didn't wake up and just had really was inpatient for the better part of a month, including Christmas. Had a really rough go of just lots of vomiting, which after abdominal surgery is not something you really want to do. My surgeon at the time, she ties really good stomas. So technically wonderful. Still love the stoma that I have, but she really thought she was not happy about this complication and me having to stay longer. And for some reason back then, I didn't know to ask for a PICC line. I never had one. And so that was all I needed in order to be able to just get some nutrition, go home, manage it at home, and then very slowly add in some sort of food, salt or even liquids without vomiting. But that was a really rough journey where she was frustrated as the surgeon and decided to tell my loved ones that this was attention-seeking behavior. And my loved ones, my mom and sister, were like, no, this is not the way she would get attention. And she really does not want to be vomiting. And we just had Christmas in the hospital around an IV pole. So that was not fun. And all I needed was a PICC line. She put it in. And now I know to ask. Now I know to encourage and advocate every parent and patient to ask, if you feel like your gut will not wake up, okay. That was one pretty big, like, okay. And I learned then, thankfully, I had a really great GI health psychologist at the time who was within that system, who kind of helped me learn how to fire a provider and to find one that's a better fit and that can handle really challenging side effects, etc. That was very empowering, very frustrating. It was a big mess, but I'm really glad that I learned how to do that, because now I feel like I've assembled a team that's really helpful for me, and that like gets me, knows me, and would never, I don't gaslight or like perceive me in that light, like that they would say, your body does some really unexpected things. I'm up for the challenge. Let's try and figure this out together. So I had that temporary loop for a while. I just was like, let's let that fistula completely heal. And I left this part out. I just remembered as soon as they figured out it was actually a fistula and not just like recurrent gynae issues, that was the tip off that this is actually Crohn's. So that was also really big mentally in terms of switching to like, I'm cured. I have this J pouch, even though it's always giving me issues, and I had to be on Humira. So there were some question marks there, but there was that saying of like, they told me that I have to do the surgery and then I'm done. And so I've kind of crossed it off mentally of like, I remember doing some sort of going to the gift shop and like buying something to like memorialize, like I am done with this weird GI chapter. And I said goodbye to my nurses, farewell, like that I was very eager to turn the page. The book is done, and the book was not done. It was just another even more confusing turn of events and chapter. So I had the loop. It actually really, once I was able to start eating, I kind of settled back into life again. I think at that point, I'm trying to remember, when did I meet my partner? I have a really wonderful partner. And so he's only known me with an ostomy. So at some point in there, I'm in my 30s, I'm in my career, figuring myself out. I had gone to grad school and gotten my MSW and was doing my internship. I worked for a long time in oncology, where I did my internship, adults, outpatient oncology. And 2014 came around. Oh, while I was working in oncology, I found out about the BRCA gene. This doesn't really have to do with IBD, but it has to do with chronic illness. I found out that I had the mutation that Angelina Jolie has. And so again, I have BRCA2 and not 1. So this is when it was kind of it was like trying to navigate, okay, I have all this IBD stuff, but it's kind of in remission. But then I also have this, like, you have this much higher risk for getting multiple cancers. We need to monitor you pretty regularly, like riding the roller coaster of monitoring. Surveillance is what they call it, versus prophylactically getting a double mastectomy and your ovaries out and all that. So 2014 is when I started getting like the false alarms, where I would go in for my mammogram or my MRI. And then fast forward, I'm a survivor. But so that was 2014. 2016, I start getting bowel obstructions. Those are really terrible, but one resolved without surgery. And then 2017 is when I had a very bizarre like back pain episode, or hip pain, where it seized up so much that I really thought, like, I have no idea what's happening, but I can't walk. It was very sudden. And it just was like over the course of a day, it was getting more and more painful, to where I ended up having to call 911, which I'd never had to do before. And then when I called 911, the EMT was like, I bet this is anxiety. He was like, you're having a panic attack. And I was like, no, this is like 10 out of 10 pain. He was like, don't worry, I have anxiety too. I'm like, I know what anxiety is. I am a trained therapist, but this is really like, I'm shaking. So I had not tremors. What were they called? It's a thing that you have when you have sepsis. So that's really good that I blocked it out though. It's called something. I'll remember it. So thankfully I was like, my husband, I'd rather you not take me to the closest hospital, because it's not actually where my providers are at. Maybe a blessing in disguise that I was able to not die in the time that my partner took me to the to the hospital where I wanted to be with good care and like the providers that I wanted to be around. And they immediately were like, you are in septic shock. This is really bad. And wheeled me in, and they did a scan and they found out that I had a liver abscess, which is a new organ that I didn't know was going to betray me. And apparently the liver kind of took one for the team. And for whatever reason, it kind of manifested as really bad back and hip pain. But they had to do kind of emergency surgery and put a drain in the liver. And then I ended up, because of my labs and then my value, like they had to put me in the ICU for 5 days. That was probably the most significant chunk of time where I still am kind of working through the PTSD of that, even though I was very out of it in some ways, but then not in a lot of other ways. And what I didn't know, so that was like our first wedding anniversary, and we had planned this big trip for his 40th. It was going to be lovely. So I just was so concerned that my health is getting in the way of our fun vacation. And they had the ICU doctor had already told my husband that I had a 50-50 chance of making it. So I didn't know this at the time. They were like, just breathe, you're doing great. Like, but the ICU is a very different place. It's a 1-to-1. Like there's someone just like watching you all day long because they just don't want you to die. And anytime you do any labs dip, they like all rush in. So it was a really scary thing. But then I was also like having vivid dreams of shopping in Europe with my mom. Like, so I would have these like fantasies. So I had no idea the kind of how intense what was going on around me, thank goodness. But I just was trying to get through it. They had like I remember this dog, they had like pet therapy, and I remember loving this dog. It was real. It was a real dog. It wasn't in my dreams. So making it through that, basically, eventually the ICU team, at first they said, it's so random. Yeah, this is just totally random infectious disease that you got a liver abscess. Like, what other person in their 30s? I'm sorry, this has got to be GI related. And then, of course, they started connecting the dots and they were like, you need to get that inflamed J pouch out that you've been kind of like not wanting to deal with because you're diverted. And I was like, well, I'll just let it kind of hang out down there. But J pouch, any organ, it doesn't want to be used if it's inflamed. It doesn't want to not be used. It was diverted and it had just been like kind of stricturing and scarring. It couldn't even be surveilled at that point. Like my GI couldn't put anything in there. So we were like, who knows what's growing in there? But I just I did not want to pull the trigger on the permanent ostomy doing a Barbie butt. But after the ICU, they were like, you got to do it. Get better, go home, get better in a couple months, and then get strong enough to do the Barbie butt. So thankfully, I'd like interviewed a few surgeons because I had been playing around with this idea. I knew eventually it would need to come out. And so I scheduled it. That was October 2017. And then January. Did it. Total proctocolectomy. Got rid of the J pouch, the rectum, the anus, changed my temporary to a permanent. And I would say haven't looked back ever since. GI wise, I've been really good ever since. So I would say this has bought me a lot of time. And I am, knock on all the wood, I am symptom free, able to eat anything I want. I've had no bowel obstructions, no ICU stays. I was asking my partner this year, hey, do I need to update my medical resume? Did I have any medical crises this year that I blocked out? And he was like, nope. That's a good year. We will probably always max out our insurance plan, but knowing that I don't have to add anything big, that feels pretty significant in the last multiple years. So I'm not on any medication. Cheers to that. I know that at some point I might have to be. So that's a little bit about my story GI wise. And then, in the background, I'm still doing all these checks for this genetic mutation. My mom had breast cancer growing up twice. So I knew I had a family history of it. I was getting some of these false alarms. And then 2019, so it was like a year and a couple months after the Barbie butt is when I was diagnosed with stage 0 breast cancer. That was pretty shocking. Even though I knew I had a high risk, I was like, I'm so young, like this won't happen. I'm doing all my checks. I do think that doing surveillance helped catch it early. I also think a bunch of it is luck of the draw. But since it was stage 0, they did not find it spread in my lymph nodes. So I had a double mastectomy with expanders for the whole year. And then a second surgery when you exchange them for implants. You can also choose to stay flat. You can choose to do this flap, like use your own tissue. That was not an option for me. That was kind of the one that I wanted to do because of my ostomy. So like they're not going to mess around with stomach and scar tissue when you have. So lots of stuff around that 2019 mark. But again, since knock on wood, since 2019, it's been quite a few years of just, again, still doing my checks, but feeling like it's really nice not to live in a doctor's office. I've been there. I know it. I can do it well. I can advocate. It's nice to have my job where I just get to see patients who are in that stage. Some of them are newbies, new diagnosis, but some are just in the thick of it with a fistula, with a Crohn's diagnosis, with upper GI, anything. So I don't see any breast cancer or actually any genetic mutation patients because I don't want that countertransfer. That it's just going to trigger too much for me. But I do really love working with GI patients, kids and adults. It's kind of amazing because I've been there, in terms of my own experience, but I also have like the clinical training too. And that's where I'm at. I'm happy to be alive and happy to be like, I don't know, just getting to know other people who have it. I just think it's the best thing ever. It's like a redemptive aspect of this. I don't think that there has to be any redemption for suffering. And I don't think I have to put like a little bow on it. Like, yay, I'm so glad I got this. But there are some positives. There are some things of like getting to meet other people and also getting to have a career out of it is pretty cool too.
I'm going to take you down the professional path for you here, because in addition to being a patient, as you said, you are a clinical social worker that is a therapist, and you are specializing in treating people with chronic illnesses, and you'd love to work with people with GI issues. So that is fantastic. We love talking to y'all. But I think you're the first therapist we've had on that has worked specifically with children. So can we talk a little bit about working with little ones with inflammatory bowel disease? How are you helping them take on this new diagnosis and not let it become the thing that is them, and cope with living with a chronic illness? I mean, chronic illness for somebody who's 10 feels so enormous. So talk us through a little bit about how you're working with kiddos.
Sure. So I like kids and adults for such different reasons. Kids just are, you never know what's going to come out of their mouth. Not that you can predict adults either, but with kids, you have to go through, sounds like a weird metaphor, but through the back door. You can't just go through the front like, hi, I'm a strange adult. Tell me all your feelings about this chronic disease. Like, who is this lady? So you do a lot of play therapy. You have to build that rapport in like a very creative way. They're not interested in like, here's a coping strategy. Let's do this therapy. So I really enjoy it because there's a lot of bibliotherapy, or we can like read a graphic novel and talk about the similarities and make little Venn diagrams. We can do Legos. I have a bunch of every poop related thing. So, I mean, I just feel like people in my life give this stuff to me, or like an organ apron, or these little squishy puzzles of different organs. So getting kids to talk about it, getting them connected to resources like other kids that have it, huge. Camp Oasis, huge. I did a lot of volunteering there as a mental health director, and just thinks it's phenomenal to get them to have a safe place and to let it be as big a part of their world internally as they want it to be. Sometimes they're just talking about whatever sport they're in. Sometimes it's like we're changing to a different treatment. This is really scary. I have to learn how to get an infusion or, inject myself. You just get to do all sorts of stuff. So you also can include the parent. Sometimes there's like separate parent coaching sessions just to try and help them make sense of it and to figure out the dynamic between parent and child when you have a chronic illness can be really tricky. And so trying to help them. But usually I'm with the kid just one-on-one, helping them figure out, how do I ask questions? Are there any kid appropriate distortions that they're worried about, that they're holding in, and helping them just have a way to get out any feelings. Usually it's like negative feelings about I'm different, I don't want anyone to know, poop stigma, I have to take meds, eating, growth, I have to do growth hormone, whatever it is that they're dealing with, trying to get them to just have a place to talk through all of that. and also saying, I'm not just here for your poop talk. Like you get to talk about anything. This is your safe place. So they know that that's like a specialty, but also some of them end up getting diagnosed with ADHD, or they're not getting along with their sibling, or the parents are getting divorced. Like there's all sorts of things that come up, but that's where we usually start, is like, hey, this is a very poop friendly zone. Nothing you can say is going to gross me out. And there's no needles and there's no exams. Like this is just talking. It's a blast. It's kind of fun. I love that I get to do it. I got to work on a project a couple years ago with Tina, but it was basically a patient handbook for parents of kids who have IBD. So there wasn't something like that. And it's kind of like this nice bound little book, and it has patients' perspectives and mental health and doctors. And so Crohn's and Colitis Foundation does have quite a few, like they have like the little comic book. They have a lot of great stuff online, but this was like a very comprehensive, like how to be a caregiver of a kid who's newly diagnosed with IBD. So I would definitely recommend that resource. And it's free, it's online. It was like funded by this grant. So that would be a good thing to put out into the world.
Yeah,
But
we'll be sure to link to it in the show notes so people can look for it down there.
awesome.
And just as an FYI, even as a parent, you can't go in direct. You have to take the back door to get your kids to talk thing.
I bet.
One of the things you mentioned is working with people who are newly diagnosed. And I think I'm curious how you help people integrate this new piece of themselves into their sort of picture of themselves. Because I do know there are some people that really are like, I don't want to identify as a patient. I don't want to be that person. But there are some people that really do use this as sort of a, like you, sort of use this as a place to sort of say, I'm going to be able to give back to the community, or I'm going to become a content creator, or I'm going to sort of use this as a thing that also adds a distinct aspect of my personality. But I'm curious how you sort of help people integrate that in, because it can be both.
It
Or
can be.
sometimes
It can be a
changes.
range. I'm all about the spectrum. So trying to, and I always normalize, like there's no like goal, like you have to be private, do not tell, or you'll get discriminated against, or just like introvert and extrovert, like we're all of it, but you probably lie somewhere on the spectrum. So in terms of how much it is a part of your identity for kids, I start out and have this like cardboard puzzle, and like they can write different things on the pieces. Again, trying to get them to see them as like, it's not just, it can almost become so much of their identity, but also like trying to figure out like, how can I keep developing friendships and relationships outside of just like my dog, depending on how ill they are. For adults, I feel like it's trying to give them permission to however much into the IBD world. If you want to this is your profession. This is, you're a content creator, you're an advocate, you want to be a GI, all those things, great. And if you don't, great. Either way, what we want is for you to live the life that you want, to have health enough to go towards that. And even if you have limits, to embrace the things you can do. Like we talked about the circle of control of like a lot is outside of our control, but we do have some things inside our control. So let's just like mess around with those variables for a while, whether it's like how compliant you are with your medication or diet, exercise. It could be any number of things, but I want to kind of give autonomy to the person in terms of how much they want to integrate it. Because some people don't really want to talk about it. So we tread lightly, but I do feel like some people need to be kind of coaxed out of their shell, because it is a shameful thing that they want to compartmentalize off. And then some people want to only talk about that all the time. And they almost need a little bit of like, and both, and like let's let there be other things in the room where we don't have to. But again, that's how they want to frame their whole identity. Who am I to say that's not good enough if that works for you? So trying to figure out like where are they wanting to go in terms of their life goals. How do we try and empower you to get there despite IBD sometimes getting in the way? How do we deal with the hard days? How do we deal with the limits or the setbacks that we're currently facing? That's or kind of how I think about it. Does that answer your question, or?
It definitely does. I mean, I think that is perhaps a little bit of the debate in my mind. And again, I'm not a clinical social worker. I am a macro social worker. So I try to work on systems, not individuals. But I do wonder about, sort of making this the biggest part of your identity, and whether that gets to a point where it's because your whole life sort of centers around this thing that is illness, and I don't know, I just worry about that sometimes, I guess, for some folks. And not anybody that I like, and not like pointing at Robin or something like that. I wouldn't have asked her to make a podcast with me, that's for sure. I guess I just worry that I wonder if it's a little bit of control. Do you know what I mean? Like, it's like if I make my entire identity about it, it's like an aspect of controlling your disease, controlling your fate. But again, who am I to say that that's not okay? I don't know. There's my entire stream of consciousness for you.
No, I like to hear that. It's interesting. I don't think there's a DSM diagnosis, but it also, you get the sense of how much it's working for the person or it's not as into it. And so I just kind of go with that because only they are going to know, is this like stressing me out or is this like not giving me what I want out of life? I would say you do need to, I don't know, focusing on those all day, all the time, probably not going to bring a ton of joy, but I bet it could be rewarding in some ways. So I wouldn't come down. I'm like, this is pathological for you. But if they say it's not working, or if I sense it is, then I would probably say like something feels a little off for here.
And I do think there's some real beauty in what happens with this too, for the people that do dive in and say, I'm going to provide support to people. I'm going to provide education to people. I do think there's some real beauty that can come. I mean, Tina's a great example of this. Like, would she have chosen the path that she has? Absolutely not. Her Crohn's is tough. It's tough to handle, but she has taken that and really turned it into, a real mission, as an example, so there's lots of people that have done this and taken this and created a very beautiful community or a beautiful piece of the community that I think can be celebrated. So
I'm with you.
Just talked myself all the way around to that, didn't I?
You made a perfect circle. What I was just going to add some color to what you were saying is when I decided to make a job change, when we were starting the podcast, when I had to have surgery and ended up in the hospital, it was my whole life revolved around IBD, my work, my volunteer time. We were just starting up this podcast. I had surgery and that went wrong. I was recovering from that surgery because of how wrong it went, was trying to find a new surgeon in the midst of recovering from surgery. Like, it was a struggle. And my life was centered on IBD, not in the most positive way. And I was in the midst of medical trauma and then having to work with doctors every single day. And every single time one of those doctors did not respond to an email in a nice way, I just couldn't. And I was sitting trying to recover from surgery, living in the midst of having panic attacks and still having to go see this doctor because I hadn't found a new surgeon yet. And so it was like a whole situation I was living in. And so every single time I got an email, voicemail, or had to work with a doctor who was a jerk in the IBD space, whether they were a man or a woman, I was just like, I can't do this anymore. While I'm living in this hell, trying to figure out my own health, it was not a good place to be in. So I had to, for lack of a better term, blow it all up.
No, you didn't blow it all up. You just drew a boundary that needed to be drawn. And that's a good thing,
Yeah.
I feel like that your whole world was revolving around it. And like I talked about countertransfer, it's too close to home.
Yep.
Yeah.
You got it at some time in that season that you can't I don't know how you could look those people in the face. So just knowing it's too much. This is not the right environment. I don't know if did you get out of there? I was going to say, okay.
Oh yeah.
Again, just like maybe not IBD or like maybe not the doctors that you have to work with or that are treating you, just like that it's so personal. These are the people that are seeing your lives, and then you're seeing like the asshole side of them.
Like,
no, you want to have the fantasy as the patient doctor. You want to have space in there. And if you don't, I'm sure there's like other situations where people are able to do it, but when you're in crisis, like it sounds like torture. It sounds like the perfect storm. Burnout, resentment for existential crisis. I would be going, that's too much.
The PTSD was real problematic there for you.
Yeah. Problematic. Well, I mean, it's 3 years in therapy now. Whoop, whoop.
All right.
Good job. Good job.
Shout out. That's great.
One of the things you wrote on there that I'm super, super fascinated with is that you do medical hypnotherapy. Talk to us about that. Talk about how you use that. Number one, kind of give a quick, like, how is this different than make me quack like a duck or bark like a dog? And then also sort of how do you use it within your practice?
Yes, it is nothing like it is portrayed in the media. It's huge in the GI world. We actually have decent studies and research and results. It started out decades ago with functional GI, aka like DGBIs. So IBS, some of the GERD, dysphagia, some of the more mysterious GI conditions. That's where it started, where the pathology comes back, everything is fine, your endoscopy, everything looks pristine, you still have terrible, these really rough symptoms. So that's where the research started. It's now expanded to IBD, and I'm sure it's going to, it's expanded to a lot of different areas, but in terms of gut-directed hypnotherapy, which is something a lot of the GI health psych people are trained in, like myself, there are different protocols based on the research of like, this is for IBD patients. And, again, within the IBD world, since it's not as, we have inflammation. You cannot trick your body into, I would say, curing anything, but the studies have shown it helps IBD patients stay in remission longer. Does it help put you into remission? We'll need more research. So it is not as woo-woo as you would think. It's like, here's a 7-session protocol. So it's not long-term. We don't do it forever and ever. We have a session, you get in a comfortable position. It's why I have a couch in my office as well as a chair, because some people like to lay down and really almost like at the end of yoga class, if you've ever done yoga, like Shavasana or whatever that is, where you just lay down, just put a blanket, you can keep your eyes open. A lot of people close them because they get heavy. And you are picturing, so I'm doing this, introduction, getting you in a relaxed state, helping you visualize, getting more and more relaxed, deepeners. And then there's the suggestions, which is, base, you can customize it too. So it's a little like improv, which I love because I'm not doing a research study. I can do like, do you like the beach? Do you like the mountains? Have you ever had anything traumatic happen at a lake or the botanic garden? Like, if so, we're not going there today. But where are your favorite places? And then these are the places where, as we're in this place in our mind together, like walking around, noticing and being mindful of all the beauty around us, your body's in a relaxed state, making suggestions, which is what hypnosis is all about, to see if we can picture healing light going all throughout your GI tract. So wherever there like inflammation is, picture, it can be really nerdy and sciencey, like little armies of cells going and rescuing getting the inflammation. So you can really kind of customize it to what kind of speaks to them, what are their interests. And then it's also just a tool for relaxation. So I give them like a home practice track that they can have on their phone or their whatever computer. And so they just have that as kind of maintenance, and you do it in between the longer sessions in person. And then you see what benefit you get. And I view it as similar to mindfulness, similar to meditation, but it's more guided, and you get these like all sorts of different analogies and different visualizations that can kind of help the body relax. It's not going to cure IBD, but it might definitely help with anxiety and depression, which we're all prone to when we have IBD. So it doesn't hurt to try. And you have to in order to get access to kind of like the library of different research scripts and things like that, you have to get trained, be a fully licensed professional, and then get trained through like an accredited. There's a lot of non-accredited hypnotherapy type of businesses. And so I went through ASH. Again, a lot of the GI health psych people do that one. And so it's just knowing you have to have a certain level, you have to get a certain number of hours. You have to like try it. They want to make sure that you're practicing quite a bit, and then you can integrate it into your practice. It's kind of cool.
Yeah, it seems like it's another really great tool to just help people, even just like you said, for the mindfulness aspect of things. So I think that makes sense. Dr. Meredith Craven was on our show, and she talked about this as well. So if you want additional information, we could definitely I'll link to her episode as well.
Love that. I saw you had another therapist on, maybe it was Meredith, who does EMDR. which is not talked about a lot in the GI space. Honestly, there's not a lot of medical trauma talk other than, hey, it's prevalent, and CBT, which again, that's one cognitive processing therapy. There's like a cornucopia of trauma modalities. I hear very little of body-based intervention, which is like the trauma happened in the body and the body needs to be involved. This is not just like correcting, thought patterns. So I think it's really interesting that in my trauma world, of all the therapists that I know are all about somatics and body stuff, EMDR being one of those types of things where you are literally integrating and tapping and integrating the memory. So whereas I feel like in the GI health psych world, in the academic like hospital, that's where a lot of these people are housed. They're not necessarily in a private practice or able to have like fluidity, or they have very limited, all about CBT, because there's been so much research and it's just like short term, I just think that there's such value to digging a little deeper into saying like, yes, that helps. Yes, this helps too. Let the patient be know all the options. So I love that you had someone with EMDR, just because I feel like it's like not as represented. It's all CBT, maybe a little mindfulness, maybe a little DBT.
That was Courtney Bear's episode, was like almost her whole episode. She like just explained went into so much detail. Because I don't think a lot of people know exactly what that all entails. Yeah, she like went into great detail about that. That is that's a hospital setting. It's not a university setting, but she's in a hospital setting at Merge. So,
and then we had you and Hannah talk about doing it and actually being the patient side of it, as well. So I think a lot of people found that helpful because again, it sounds weird. I mean, just to be completely frank, it sounds weird when we talked about it, even as we were talking to Courtney about like going through the process and sort of how it happens and how fast it can help. It just seems like it shouldn't be a thing. And so it was nice to have kind of both perspectives on that one, because I guess I'm sort of surprised that it's not more utilized in more academic centers. Why?
I'm saying around GI, but I feel like within, I don't know, there are some centers that do. The VA system is EMDR has been for a long time with that.
That's really where it was kind of piloted, wasn't it?
Mm-hmm. So now I feel like it's just starting to get to like other medical traumas, other diagnoses that are traumatic versus just veterans, like kind of the people that you think of that would need that, but thinking outside the box.
If you don't mind sticking with medical trauma for a little bit longer, because you mentioned that a couple of like, instances of medical gaslighting. I am curious how you are, patient 127 that we've talked to that has brought up some aspect of medical gaslighting. And it is very traumatic to not be believed and to have somebody basically, turn your reality on its head. From the therapist perspective, how do you help people process that? Because some folks don't have the opportunity to go to somebody else as their provider. They don't have a lot of choice. They have to keep going to the person that's been the person that is the jerk. So how do you help people advocate for themselves and go through that?
Yeah, that's a great question. If they don't have choice, I guess I'm a little skewed because I live in the city of Chicago. And so there are other providers, but if they were within different like insurance or financial constraints, ultimately you want to give the provider benefit of the doubt and have a conversation with them. So it's usually some like rehearsing and getting clear about what you want from this conversation. What do you need to hear in order to kind of rebuild? There's been a breach of trust. So you need to be able to be pretty explicit with, this is what happened. This is from my perspective. This is what I would need going forward to keep, I want to clear the air. I need to have a conversation, and seeing if they can't. I feel like there just needs to be a lot of coaching and a lot of room to say, first, we're going to do one with all swear words, and you're going to say anything, and it doesn't have to be constructive anyway. And then we're going to try and figure out, okay, what are our goals in this conversation? Do you care about what if they're offended, if they react this way, how do you still hold the boundary? How can you, strategize, again, circle of control, like before and after this conversation, what are the preparations? Who can you bring with you? How can you go in feeling as grounded as you can? And then afterwards, we need to have like a self-care plan, because this is going to be extremely taxing. The power dynamic, let's talk about systemic health. So just giving them a lot of room before they have to do whatever the conversation, whether it's breaking it off or saying, this didn't work for me and I need it to change. And that is my right as a patient, like to have open dialogue with you about that did not feel good to me. That's hard. That stuff is really hard because there's so many emotions involved. I would call it disenfranchised grief, and the fact that it's so, if you lose a provider, even losing a medication, people don't get that. Like, oh, but there's another option. Aren't you so grateful? Oh, you're in remission. Like, no, there's a lot of loss. I already have so much loss, or there's trauma. I was attached to them and they broke my trust, and I don't want to fire them, or I can't fire them. Now I have to go face this person, put my life in their hands while I'm let's say it's a surgeon, like I'm going to be under anesthesia, have no control, and I have to trust this person. And so just doing a lot of validation about like, what is medical trauma, and that it's okay to have all of the complex feelings. And then we get into kind of a settled, more clear place of what do we need to do from here? Yes, this was not right. Let's call it what it is. Let's name it. And who do you need to kind of stand in your corner? Do you need me there? How do we try and get your support so that you feel like I can do something about this and that you're not trapped and hopeless and hopeless?
I'm really glad that you just asked that question, Alicia, because I think about if I had to have my second surgery by that surgeon, I don't know what I would have done. Like, no amount of therapy would have gotten me through that.
Yeah.
I don't know what I would have done. I would still be walking around with a loop ileostomy right now. I would not have been able to do it.
Mm-hmm.
Well, just even how that affects the outcome of your surgery, too. I mean, going in with those significant doubts and fears cannot help your recovery.
Right.
No.
That actually touches on hypnosis too. Pre-surgery, there's great scripts to help the body go in as relaxed as possible. Again, that alliance with your surgeon, that trust. I'm in a teaching institution. I've gone over all the things. But also there's a quote, I can't remember who said it, but the body cannot decipher between the knife of an attacker and the knife of a surgeon. And that is profound. The mind can't. And I'm paying actually to go through the surgery. This is for a better quality of life. I am going to choose this. The body just knows there's a scalpel, a knife, and I'm being attacked. So using hypnosis as a pre-surgical tool, I even have this like CD set of stress-free surgery. I don't believe I would use it for anesthesia. I'm a big fan of medications. Give me all the things. I don't want to wake up or remember that. But to get the body in as relaxed, especially with kids, we see this even for procedures, the more upset and overwhelmed they are as they're going into anesthesia, the more they wake up in a very sometimes aggressive, just really dysregulated screaming state. So that's why child life specialists are huge, because they're in the setting with them doing the box breathing, doing any of the VR goggles, like they are putting whatever scent they want on the mask, and they put the stickers of whatever characters. It's trying to knowing that the body is the thing that we want to just like establish that safety and trust of like, this is scary. It might be confusing, but I'm here, I'm safe. And being able to kind of calm it each step of the way is pretty big. So to have a breach like that, it makes sense why it brings up so much for you, Robin, of like, I can't imagine. And I'm guessing if that happened, that the patient just wouldn't do it, right? Like there would be enough. I mean, again, if they were able to, if it's emergent, but
yeah, I mean, I know me even saying that is like just reeks of privilege, but I just can't even, I can't imagine having to make that choice. And I know that people have to all the time.
First thing I was going to say when you stopped telling your story was, I am so sorry that these people said these things to you that are so wildly inappropriate and so painful. Yeah. And people have no idea like how devastating those types of like little one-off, like, oh, but I have anxiety, so that must be what it is, kind of comments can just be so life-altering for people. So I'm sorry.
Yes. Thank you for validating that. Yeah. People are not the best sometimes.
No.
And I want to give people the benefit of the doubt, right? You want to, like the guy that was on 911, like I'm sure he was trying to calm you down, but at the same token, like, dude, you're calling 911. Like people don't just call 911. I guess some people do just call 911 about chicken nuggets and weird stuff like that. But like,
I just remind myself of that, like, especially since my daughter Logan has worked in the emergency department, I remind myself that like people do things like that. There is a reason why people say stuff like that because it does happen, but also no.
yeah,
Right.
but
No,
also
sir.
believe
But also,
people.
no, sir. Keep it to yourself.
Right. They were called,
Keep it to yourself.
I just remembered, Rigers, or that's like,
Rikers.
it's like whatever, it's where your body is in septic shock, your tremor, you're shaking. And I was like,
Yeah.
well, I can't, and your teeth chatter. And I was like having to put like a blanket in my mouth because I was like, I'm gonna like bite my tongue. What is this? I
That's
mean,
so
I am in a
weird.
ton of pain, but I'd never had that. Again, now I know the word. Now I know what was going on. That would have been helpful. It all makes sense in hindsight. Now I know what.
Yes, Steph. Really sad that I have to ask you this because I just told Alicia that there's so many more things that I want to talk to you about. We didn't even dive into half of the stuff that I had on my list. So, but it's time for the last question. So, what is the one thing that you want the IBD community to know?
Mental health is so important. And it's really hard to find a good therapist who knows about IBD or chronic illness, but it is worth the legwork. And even if you have to reach out to Google me or go on, I will help. I love to connect people. I can only see people in Illinois. I'm full, but there's not enough of us. So we need more GI therapists, but there's also a website called Rome, like the city of Rome in Italy, Rome GI Psych. And so all of us who are trained are there as listed on our profile. So that's one resource. I want every IBD patient to have access to someone who gets it and who is trained to help them. I believe it's a right as a patient. I believe all the, integrated care model, we're moving in that direction. We're still so behind. And so I want every IBD patient to know you are not alone. Depression, anxiety, trauma, all of those things, we are ostomies. All of those mental health things, we are at high risk of getting, and that's not your fault. Gut-brain connection. So just knowing like this is going to be in 20 years, 50 years, everyone, it's going to be one-stop shopping. Here's your GI psych, here's your dietitian, here's your GI, here's your surgeon. We're not quite there. And just know that no matter where you live, you deserve good comprehensive care for the whole person, including your brain. That's my soapbox, and I'm sticking to it.
I do want to ask you a final question, but because you had a really great comment about what you would want professionals to know for your one piece of advice.
It's on us as providers to ask the hard questions. Therapists, we're used to asking all the hard questions, but the GIs, that is the ostomy nurses, the APNs, everything. We're starting to again, some systems will ask, do you feel safe at home? Or do you have depression or anxiety? That's all. That's assuming a lot. So having that integrated into your paperwork and having a conversation and making sure that there's privacy so that that person will feel comfortable enough to share their sexuality, their eating behaviors, their addiction, all the things. Yeah, it's on us as providers to assess in a really tender way, even when we're pressed for time, even when we just need to get the next medication and the next patient medication prescribed and the next surgery scheduled. We have to be willing to go to those messy places because that's going to affect patients' outcomes. Honestly, if that's how I can convince the medical provider, that's usually where I go. If I speak to them, I say, don't you want great outcomes? Don't you want great patient satisfaction scores? You don't get that unless you have that rapport where you can really go around the edges and not just the GI disorder.
It reminds me of what you said about working with kids too. It's it takes a while to build that rapport with kids. You can't just go in and be like, are you depressed? I think there's lots of people that would say, no, I'm not depressed. But that once you start saying, but how are you sleeping? How are you eating? What's your quality of life? Are you still doing activities that you enjoyed? How come you're not? Then you start to get that pattern that then helps you perhaps help somebody identify that they may be experiencing depression and they didn't necessarily realize it at the time. Building the trust with your patient and having them understand that you are that safe space to have those conversations, I think is a piece of building your relationship as a gastroenterologist or as a nurse practitioner or whoever it is, that's part of this care team. So I think that takes time.
Opening the book, but also saying, like, if they have a lot of concerns in terms of mental health, saying, just as I would refer you to a surgeon, if you want to, it sounds like you could really benefit from some support. And also all the new patients, this is one-stop shopping. Look at this. We have someone, you meet with them once, so they're there if you ever need them. They will assess, and then they'll, again, send them to someone outpatient where I have unlimited freedom and visits. They might have like a short-term model in their practice. Great. But you don't know unless you ask. And that should not be the case. It should be advertised,
Yeah, for sure. Well, Steph, this was such a delight to talk to you. And like Robin has already said, like we have so much more we could talk to you about on your own personal story as well as your professional. So I apologize that I took you completely down the professional path, but I love talking to mental health providers. So it's always so fun. But thank you so much for coming on. We really, really appreciate you being so open with your story and sharing so much of your professional and your personal story. Thank you, everybody else, for listening, and cheers, guys.
Cheers, everybody.
Hi, everyone. This is Steph. If you enjoyed this episode, please rate, review, subscribe, and share it with all your friends.